Okay, so we talked yesterday about health costs and that administrative costs are high in the United States. Also, earlier we've mentioned that Dr. Yuval Reinhardt noted that most of the discrepancy in health costs between the United States and other developed countries is higher prices here rather than an increased volume of care. So, this is a pie chart showing where basically all the money that's spent on healthcare in the United States goes to. It's not surprising. Hospital care is a big portion of spending. And that, by the way, includes both inpatient hospitalizations and day use of the hospital. For example, I had a carpal tunnel release. I was only in the hospital for 5 hours or so, waking up, getting the surgery, waking up from anesthesia. So that's not an admission, but that counts as hospital care. So that's the big sector. And then the other doctor services, dental, it's all there. And where's the administrative cost? Please speak up.
I feel like it says like government administration, like 1.2, but
Yeah.
kind of think that it's embedded within all of the slices. Like little parts of all of the slices have some admin costs to them, whether it's, billing or whether it's like I feel like 1.2 still seems very low to me.
Okay. So I thought that we were going to have a long discussion, but that answer is so correct that I'm just going to pick up on what you said. That's exactly the right answer. I should say, the most complete answer. Um, so let's look at the lower left. Um, and Survey found government administration. So that's the money that's paying Susanna Bernheim's salary. The whole Medicare bureaucracy, maybe other government programs, maybe even they count the administrators at the CDC and at the FDA. I'm not sure all that's included in that, but certainly the Medicare and Medicaid administration, the administration maybe of the community health center program might be in there. Danielle, did you have your hand up? Okay. Um, and then the one next to it to the left is net cost of health insurance. So that is the insurance money that's spent within Humana and Centene and Blue Cross. So that's their money that they spend on administration. But Survey is exactly correct. That added up to 7.2%, those two slices. But then government public health activities, well, let's not even count that. Um, and then investment is what they're investing in, like organizations like Humana have a whole lot of money that they can invest, and the pharmaceutical industry has money they invest. So prescription drugs down there was 8.9%, but they also have a lot of money they invest. So anyway, so that could be counted too. Other personal health care might be massage therapy, chiropractic, uh, other miscellaneous things. It might even include dental, which I don't otherwise see. Dental's around 4 or 5%. But going back to Survey's comment, so now let's go to hospital care. And hospitals in the United States have billing departments that are very, very huge compared to Toronto. So, for example, the University of Toronto is one of the largest hospitals in Canada. It is, or I'm sorry, all of Canada. The study was out of the University of Toronto, but all of Canada has fewer billing clerks than the big hospital in North Carolina, whose name blanks, I'm blanking on, but the largest hospital, tertiary care center in North Carolina, has more billing clerks than all of Canada. Now, it's a large hospital, but still, it's quite remarkable. So we have incredible numbers of hospital billing people. At the higher level administration, there's strategic planners, people who are worrying about costs and spending time on figuring out what to do with, should they get into a value-based care deal? What's their strategic thing? What are they doing about Medicaid, uh, Medicaid managed care or something like that? So um, the same to physician services. You go to the doctor and there's a certain number of billing clerks and there's many a lot more of that in the United States, much more spending and personnel than in other countries. For other clinical services, other personal health services, there's a certain amount of administration. Now, if you went to a massage therapist, their administrative costs would not be zero, but chances are a solo practitioner massage therapist at home at night is maybe billing or something like that, or doing their books. So there's a certain amount of administration, but it would probably be fairly small and done solo. So, and that's a tiny fraction of overall health costs. But Serby is exactly right that home healthcare agencies, nursing home facilities, hospitals, doctors' offices, dental offices, they all have a certain amount of administration, and that's way higher in the United States than in other countries. Okay, so thank you, Serby, for that. That was great comment. But now let's go on. Let's go back to Yuva Reinhardt. So, okay, so fine. We have high administrative costs in the United States in every sector. And then we have these insurance companies that are 100% administrative costs. Okay, so maybe that's 30 or 30 so percent of overall spending. I don't know. Now, by the way, I want to make the comment that in Canada, about 16 or 15% of of budgets of hospitals are spent on administrative costs, even though their billing department is less than 1% of that. So a certain amount of administration is necessary. For example, I mean, can you think of examples of why you need administrators in hospitals?
Feel like it would be like maybe to communicate with government officials and regulations and making sure like their hospital complies with those.
Yeah, who's going to do the hiring? Who's going to make sure that some people come to work and are not late? And who does the schedule? So, who does inventory? I mean, there's a lot of sort of non-direct services work. I mean, I don't know how to divide every bit of it up, but basically there do need to be administrators at the hospital to hire people and to facilitate just, necessary administrative work. In the United States, we double their percentage. So probably if you saw a figure in Canada and call that the necessary amount of health administration, or a hospital in Britain, it won't be zero, and it's probably going to be more than 10% in those countries, especially a country like Britain that's very streamlined, with the National Health Service. Their administrative costs are probably 10% or something like that, just to sort of move things along, get it to work. Who's making sure the building is in proper shape? There's a lot of issues. And then they have regulations in England. You're going to do, I don't know, maybe for poor people, they provide transportation, and somebody has to make sure that there's a functional department that's doing that. So there is necessary administrative work. But in the US, we at least double that. And it's just a lot of spending. Okay, so fine, we're spending a lot of money on administration, way more than other countries. So going back to Yuva Reinhardt, does that affect the volume or the price?
It affects the price, but not the volume.
Does anyone disagree with that? Do you want to go into more detail about the steps by which that affects the price? Does that question make sense
Because,
to you?
yeah, well, my thinking was that you have to pay for all of that administration out of something. But those administrators aren't necessarily increasing the amount of care that can be given to people.
They're not providing it at
Or
least.
increasing the amount of care that an individual can purchase. They are just being paid for additionally out of that price that a patient or a customer is paying.
Okay, so let me rephrase what you just said. So they earn money at the hospital for their administrative work, let's say it's a low-paid person who fields all the the denials of payment by insurance companies. I mean, somebody gets those denials and then they fight back. So they're going to be making phone calls back to the insurance company saying, your reason for denying the claim is invalid. You should have paid us. Get to it. So then they say, well, we didn't pay you. We had a good reason. So all this argumentation goes on the phone, and the person who does it gets paid. So that's an administrative job that wouldn't exist in maybe any other developed country for the most part, or would be minimal anyway, else abroad. But here we do a lot of that. So, and by the way, there was a study on emergency department billing, and basically the article effectively said that every additional clerk you hire to fight back at payment denials is worth hiring, because if you really fight back, you can win. You can get the insurance company in trouble if you're willing to hire enough people to do it. So anyway, so you hire those people, they're not doing direct patient care, really, as far as the patient can see, they're not doing anything useful, but their salary has to get paid. So now let's go back to a patient who's getting a bill. So let's say the bill for in the emergency, let's say they went to the emergency department and their bill says $1,200 or some amount of money. Out of that $1,200, all the departments in the hospital that are not revenue generating, you have to add that amount of money into every bill that's sent that for a billable part of the hospital. So, in other words, the salary of the CEO and the salary of the person who's dealing with billing denials, they are effectively put into the bill that the patient sees when they actually use the hospital services. So every bill in the hospital includes those costs in a hidden way. So your bill is inflated by however much money it takes because you're having to include all those salaries that are not directly linked to a patient service. So that would also be true of the laundry in the hospital. In other words, when a patient sees their bill, it doesn't say we cleaned your gown or we cleaned your room. So the cost of the person who cleans the room of that staff and the cost of the nutrition service, that you don't see bills for your meal in your hospital bill. So all of these administrative costs are just in your bill. They're not itemized. It doesn't say this is the amount that paid our CEO who's getting this ridiculous salary of $4 million or whatever it is. This is the amount of money that goes to, if you're at Hospital Corporation of America, biggest for-profit hospital chain, it doesn't say this is the amount of money that goes to our CEO salary. It just says hospital, 4 hospital days. Now, certain parts of the hospital have bills that are extra high, where the charge is higher than every cost you could possibly include, all the costs, and one of those is the lab. So in the lab, you have lab workers and they have to buy equipment and they have to buy all kinds of stuff and reagents and get their machinery updated, their culture counter, whatever they have. But if you even assigning administrate a lot of it, their portion of the administrative costs, that inflates the bill further. But some portions of the hospital are called cash cows, and the lab is typically one of them. Well, they add even more onto the bill for labs. And so there the charge is higher than even including all the costs. But leaving that aside, the cost of administration is included in all these bills. And these administrative costs, as Sorby pointed out, are in home health departments who have to spend a lot of time billing and interacting with doctors to get us to write the right thing so that they get paid. They get paid when a doctor gets the referral filled out correctly and the referral form is complicated. Anyway, so those issues are dealt with administrative employees and anyway. So, and in doctors' offices and hospitals, all these places we see administrative costs. Even in a community health center, somebody writes the grant, somebody does the billing, somebody deals with billing denials. So it's everywhere, even in, organizations that, doing super essential work, they have all this to contend with. Okay, so that's administration, and that's one factor that goes into the price. But now the hospital, a frequent cause of hospitalizations for my work, which is I'm a hospitalist. So a very frequent reason, we take care of all the admissions, the medical admissions to the hospital. If the patient is a surgical admission because they have a cholecystitis, then that would go to a surgeon. But in the ER, they kind of sort out what's a medical admission, which patients can go home. And so if there's a medical admission, somebody in our service will get called. And we go down there and examine the patient and write admitting orders. And I might prescribe a bunch of drugs, and the cost of those drugs is in the hospital bill the patient will eventually get. So if the cost of prescription drugs in the United States is way higher than other countries, then that may not show up in that prescription drug sector, but it's going to lead to higher price to a higher hospital bill, a higher price for the hospital care than it would in another country because we pay so much for prescription drugs. We also pay more for coronary stents and almost every other item that goes into the hospital. It's kind of getting back to the Macaulay rule that everything's inflated. People will make money wherever they can in the healthcare system. So that stent may not be itemized. The bill may just say coronary revascularization, 3 vessels, 3 coronary stents or something like that. But it's mostly billing for the procedure itself, and all the tools, the catheters and all that, they're likely not to be on the bill. But all these prices are inflated in the United States. So if you wanted to have a healthcare system that's efficient as other countries, you can take advantage of not monopoly, but monopsony power. A monopoly is where only one company produces an item. A monopsony, otherwise known as a single payer, is where only one entity is doing 100% of the purchasing. So monopoly is on the vendor side of the supplier, the producer of a thing, whether it's prescription drugs or whether it's a coronary stent or an aspirin tablet. Somebody produces the item and then somebody purchases it. If you have millions of purchasers, they're not going to be in a position to stand up to the pharmaceutical company or the companies that are producing coronary stents and saying, why are you charging $1,300 for that stent while they pay, $400 in Germany or whatever the cost over there is. I think it was $350 or something like that in Germany. So on the other hand, a monopsony, a single payer, can sit down with the company that's producing the stent and say, we're no longer going to pay more than what the German hospitals pay or the French hospitals. We're now negotiating. And we're negotiating on behalf of every single hospital in the country. You want this market. This is a big market. We have 340 million people in this country. And a whole lot of coronary interventions are done. So we're going to negotiate now. Now, yesterday, I think it might have been Chris, I'm not sure, but somebody brought up, or it might have been Nehemiah, brought up the disadvantages of trying to beat down on payment to specialists. So let's go back to coronary stents just for a second, using that discussion that Nehemiah raised. Okay, so you're a very strong negotiator. You're really a strong negotiator. You're negotiating for 350 million, 40 million people, and we use a lot of services, compared to Namibia, or some extremely poor country where they can, doing well to just provide primary care. So you're a strong negotiator. You're in a position to negotiate the cost down, but is there a lower limit to that negotiation?
I'd say so, probably.
What is it?
I think kind of like you were referring to already, you probably couldn't go too much lower than other countries are paying for the same services. As well as you probably couldn't go too much lower than what you know they would feel is at least a fair compensation for the, what it costs to perform it, and then them probably taking some home as a profit. You probably couldn't go too much lower than that.
That's a great answer. It's exactly right. So they have to produce the item, they have to transport it to our hospital to deliver it to us. They have to have researchers who try to improve the item. They have to have a department that takes complaints from hospitals and doctors who found there was a problem with their stuff. So they have to do what it takes to produce the item. And a single payer might be in a position to reduce the price. But if you go too aggressively, then you could either not even be able to get the item. There's just a price that's so low that they can't even do the work. And there would be another higher price where they could do the work, but they couldn't do enough research. So there needs to be kind of a common sense aspect to this negotiation of how yeah, a monopsonist, a single payer is in a very strong position, but you better be careful using that power. It's the same thing. If you created a fee scale for doctors where you were knocking down the fees for orthopedics so much that nobody would go on into that field, then we'd have a shortage of services. So purchasing is actually an area where understanding how monopsonies work, it semi works in terms of microeconomic theory. It's not in the first chapter that talks about large number of producers, large number of consumers. That's where the classic free market stuff works. But there is a chapter that talks about monopsonies, and there is a lower end to how powerful the monopsony can be. In the same vein, a monopoly um, that is the only producer of an item, they can try to raise the price because that way they make more money, but there's an upper limit. If they raise the price too much, nobody will buy the item. So, and then in between, you can have a cartel where there's a few producers, or on the other hand, like Australia, you could have a few, where there's a couple insurance plans. They're probably still both in a strong position to negotiate, but maybe not as strong as it would be if they were only one. But the point here is that the single payer gives you a effector arm, the structure to begin to drive down prices. And the first step is that you have to care about prices, which in the United States sometimes almost seems to be missing. But at any rate, you have to care. And keep in mind that the structure of a single payer system is that every price increase directly leads to an increase in taxes, which won't be popular. So now in the United States, that also happens but it's more indirect. Like if Medicaid is one of the payers for a hospital and your state taxes pay for your Medicaid program along with the federal match, if healthcare becomes more expensive, which is what happened in many Medicaid programs across the country in the last few years for a variety of reasons, the pandemic, the fact that so many healthcare workers exited and are demanding higher salaries. So for a variety of reasons, healthcare is getting more expensive and all the insurers are having to raise their rates, including Medicaid. And ultimately, we're paying for it either in premiums or in our taxes. So I'm paying taxes for municipal employees who have to get health care. I'm paying my taxes for extremely poor people who are insured through our Medicaid program. So we're all paying anyway, but in a single payer, it's more direct. I mean, that cost just gets right added on. It has to be paid for some way. So we have a motivation to care about prices very strongly in countries with single payer systems. And in the US, it's also chaotic, and it even seems like there's not that much motivation. Anyway, so let me go further on. I want to get to the end, actually.
Dr. Malek, I have a question.
Okay.
I was wondering, what are your views on like funding hospitals on an annual basis? I think like we just saw yesterday a movie in which it showed like Massachusetts follow that model, where they annually fund their hospitals to like regulate the cost. I mean, I'm not sure if that helps in like regulating administrative cost and like how hospital in the end ends up paying out for the services. But just wanted to know, like, what do you think? Would it be like one of a possible option other than single payer that can help with like regulating the cost that is being spent
You know,
on every that
I can
medical?
give you an answer, but I have to say that Dr. Adam Gaffney is going to be here on Monday, and he's going to cover using a annual global budget for the operating costs of hospitals, and then how capital costs could be kept separate. And that is really important in leading to the right amount of technology so you're not over bedding, meaning having too many hospital beds in an area with a lot of people with what's called a favorable payer mix, meaning it's a suburban community or some area where there's wealthy people. You know, you can match technology and infrastructure size with the needs of the community. And that ends up being very favorable for both the health needs of the community and for controlling costs, because you're not putting way too many beds and, coronary suites in, duplicative services that become expensive for these various hospitals to run. So just to give an example, there's many situations where hospitals right across the street from each other that are competitive, both have the very same services that they could consolidate and have done more efficiently and probably higher quality care. So, smaller hospitals probably shouldn't be doing many types of cancer surgery because they don't see it enough and they don't have enough experience. And it also would be cheaper to centralize, many types of services. So if you can separate capital costs from operating costs, you can kind of accomplish that. The global operating cost part of it also tends to lead to more efficiency because it reduces administrative costs. So those are the arguments. Now, I would like you to ask Dr. Gaffney how effectively using a global budgeting within a complicated multi-payer system, what's the difference between what Massachusetts is trying to do and Maryland is doing to some extent? I don't think any other states. Vermont has talked about it. We haven't done it. What's the difference? So he's going to give his talk, and it's going to be on national. It's going to be more national for a genuine single payer system. But your question should be a really good question to put at the top of the list. And you're hosting, I think. Oh no, you're not hosting Adam. But whoever's hosting Adam, make sure that question comes up early because there's lots of things you may want to ask him. But this is a great question, is what are the limits of having a global operating budget, trying to have global operating budgets within a complex multi-payer system, doing it at the state level?
Okay, sounds
And
good.
I mean, the first thing I'll tell you is that we have many payers. Here in Vermont, we take care of skiers who break their tibia and their femur, and we make money off of them. We bring revenue to the state. I worked in a hospital that was near Okemo ski area, and we took care of all these, skiing related injuries. And that was fabulous. It was bringing revenue into the state. It was helping to fund our hospital. So I don't really want a global budget. You know what I'm saying? Like our hospital and our state both need that revenue. On the other hand, if you're talking about the medical costs of Vermonters, people who live here, we would want to reduce the amount of money we have to pay to our hospitals for the work they do taking care of Vermonters. And we want that to become efficient. And maybe a global operating budget will somehow make that happen. I'm not sure how, but it might.
Yeah.
But the capital cost part of it, which Adam will talk about on Monday, I don't think you get that advantage at the state level. So the advantages are much more limited. But please ask the question to Adam because I'm sure he'll give a better answer than I just gave. But
Okay.
this is a fabulous question, is how can operating costs work if you leave the whole deal as a multi-payer system? It's a very sophisticated question. Anyway, so yeah, I'd throw that one at Adam. You know what's a shame is that the morning session on Monday, they're going to keep alluding to it, and it would have been better to try to get Adam first. But both of them, all of that day, this Monday was extremely difficult to schedule, so we got what we got. But I think you'll learn a lot on Monday anyway. But yeah, that's going to be a big topic: how to pay hospitals, how to plan the urban infrastructure in big cities with, a lot of healthcare needs. Okay, so any other questions? Hopefully not quite so difficult as that one. I'm just joking. I'm gonna get through this. Okay, so we're gonna go to my proposals. And I want you to, by the way, I'll repeat all this because it's so important. Don't rely on one strategy, no matter how much you like it. Evaluate every strategy, be ready to change and adapt. Fight entrenched interests, get ideas from the trenches, talk to the people on the lowest level in your hospital. Ask the janitor where the waste is. The janitor will know, be able to tell you. You just have to talk to this person. And this is how it goes. You can learn a lot by talking, going ground up. Look at models from abroad and fight for every percent. Okay, we're going to get through this. Okay, so health administration, we just talked about how all the administrative costs within a hospital are then they sneak into every single bill for a service the hospital provides. So it raises the prices. And if we're wasting, 15% of your hospital bill is unnecessary administration from these bloated billing departments, then that raises your bill by 15%, whatever percentage of the spending that the administrators are. All these managers you're seeing on this slide, they all have to get paid. And if we hired an extra one to deal with the value-based care that Susanna Bernheim is luring us into or forcing us into, then that person, whoever is dealing with the contract that has to do with the value-based care, is an administrator who has to get paid. And that won't be a low salary, by the way. And they may have a team. So all money that goes into profit at a for-profit hospital and the mailings to their investors and the CEO salary and all of that, you don't see that. That's in your bill. It's an extra, 2 or 3%. That's just in your bill that you never really see. Increasing the price every step of the way. if Springfield Hospital had to pay money to a reinsurance company, that's not on your bill, that just gets added onto the price. The hospital bill, the fees, or whatever you want, the fees or the price, whatever you want to call them. So here's the alternative. Let me get through that. Okay. So here are all the cost controls that are within this single payer reform. These are big. These are the biggest ones. But let's just look at one. So reinsurance I just mentioned. Now, a hospital has a personnel department, and that personnel department works on health benefits as part of their job. They might work on whether you get a pension as an employee at the hospital, but all these employees expect to get health insurance. And so in a single payer system, no personnel department deals with health benefits because you have a comprehensive single payer system. Well, let's just say you're in Canada. So in Canada, their system's not comprehensive. It doesn't include nursing home, home care, prescription drugs, or dental. So their personnel departments in Canada may exist, and they do exist. And they provide dental benefits and prescription drug benefits for their employees, and maybe even a little nursing home care, I'm not sure. But they do provide dental and prescription drug coverage. So by not having a comprehensive healthcare plan, Canada adds on a little bit of administrative costs to they add some administrative costs on. A country like England, where there's a comprehensive system, they don't have to do that. So so that one related to prices, that there's lower prices for the hospital if they can eliminate part of their personnel department. How about this one? Here, a single payer system provides a comprehensive database which can detect variations in care. So I gave the example of a primary care doctor who's billing for 95 patients in a day. When that may be fraud. So is that going after volume or price?
Price.
I think volume, right? Because there's 95 bills, and you're saying that volume is too high. This is due to fraud or potential income. So that one's volume. Most of them won't be, but that one is. Okay, planning to match technology with need. So here there's a notion within economics called supplier-induced demand. In other words, communities that have more MRI scanners, let's say there's two communities, both with a population of 1 million in the metro area, and one of them has 25 MRI scanners and the other one has 5. Same size population. Their medical needs, let's say, are identical. Their health profiles are identical. The one that has 25 MRI scanners will tend to have more MRI studies. And that is dysfunctional. It may be that the community with fewer MRI scanners doesn't have enough, and so the better quality care would have been to do more. But that's what's found. Those are the data that if you have more coronary revascularization suites, you tend to do more coronary procedures. So that's not in chapter 1 or even chapter 3 or 4 of your microeconomics textbook. It's later on, but there is a notion of supplier-induced demand. And what's more familiar is when you see an ad for a super expensive psoriasis drug on television, and again, I watch the regular networks, so we get, there's tons of drug ads. It's almost all it is. And that their goal is to have supplier-induced demand, that they're going to hype their drug, make it sound like the best thing since cherry pie or apple pie. and make you want to buy their drug. So essentially, all advertising is supplier-induced demand. And so doctors if there's too many doctors in an area, they may suggest follow-up visits more sooner, or even do marginally necessary procedures. And that would go after, if they did marginally necessary procedures, that would go after volume. And if they can, and so that would be primarily a volume strategy to match technology with need. And so here you're seeing more on volume. And if the system spends money on public health, which may require fewer procedures, that would also be a volume one. However, within single payer reform, the two strategies that lower prices are much more important than these three strategies down here that might reduce volumes. The two strategies which merge into one, is a drastic reduction in administrative costs, and you can drive a major reduction in prices. So day one of initiation of a single payer system in the United States, you would go to the drug companies and say, we're done. We're no longer paying more than they pay in France or Netherlands or anywhere else. You'd begin to drive down prices for all the system inputs, and then the reduction in administrative costs would also greatly reduce the taxation that you're going to need to fund the system. And that's going to mean that the administrative cost is going to lower the prices, essentially prices, by getting rid of that work. So you could banning for-profit entities. Would that go after volume or price more?
Price.
Absolutely. They're going to have to charge more and divert that money. You heard in the private equity talk that step one of a private equity company, first thing they do when they take over a healthcare facility is drastically raise prices to whatever they can get away with. So yeah, I agree with that. And all this other privatization, it's basically adding administrative costs, diverting money, making everything a lot more expensive, but not really increasing volume. In fact, all this denial of care might reduce volume a little bit, but the added cost of the diversion of money and putting our tax money into their profit is just adding to the price of the whole system without possibly even reducing volume a tiny bit with all their denials. Eliminate medical advertising, never useful, always deceptive, may not be legal, and with the current Supreme Court. Drastically limit lobbying somehow, that's just adding costs. So for example, our hospitals, they have lobbyists. You pay your bill at the hospital, and a certain amount of money in that bill is paying for the hospital's lobbyists. Well, that bill is pretty high. I had my only lifetime health scare 4 years ago, around the beginning of the pandemic. It was like some sort of rheumatologic weirdo thing happened. And I mean, the bill I got was astronomical, and all I got was, you know, two blood draws, chest x-ray, and 3 doctor visits. And it was like a huge bill, most of it for the labs, and I just felt like, every little unnecessary cost that's built in there, I wouldn't have minded if that bill had been, $2,200 rather than $3,300 that I paid out of pocket because I was in a high deductible plan at the time, unwillingly. Anyway, so, cutting every little bit, that's what I say, every little bit of this fight you should do. So lobbying is not helping anything, and to be spending undue amounts of time and with government relations, it's just money. So, hospitals, you'll talk about Monday, but doctors, we did talk about this, and the single payer could reduce compensation to doctors. So you're going to call that a price, right? The price to go to the doctor, the fee. Price and fee I'm using interchangeably. So with the caveat Nehemiah raised, which is you don't want to drive down the fees too much or nobody's going to go to medical school anymore. So, but the government is in a position to reduce compensation if it chose to do that. Okay, so that's on the fee side and the price side. If we had a functional electronic health record system in the United States, and the government developed its own software and gave it to every practice in the country, and we stopped paying these inflated prices, is that going to affect the volume of care or the price? That's should be kind of clear, right? Is that going to affect volume? Probably not. You're just going to have a different way of documenting your work, right? So this is price. So this is built into the hospital's fee structure. Is they're paying a huge amount of money to the software vendors, training their employees. And let me just give an example. When you hire a new employee, several days of that employee's salary will go into learning the software. When you hire from some facility that has a different electronic health record than yours, they'll need all that time. But if everyone in the country had the same software and they were linked, then the care involved would be more efficient. You may get a lower volume of procedures because they won't be repeated, but also you won't be wasting money retraining people who've already learned one software program. And hopefully the quality of the software will be less, and the amount of money paid to the vendor would go down to zero if the government's just giving everyone software. So this primarily affects price, but if we had great information from all the other providers a patient treats, it might even go at volume a little bit.
Dr. Malek,
Yeah.
I have a question. I'm
Yeah.
just, as I'm listening
Oh,
to
we're
all
over time. I'm really sorry. I didn't mean to do that. I really meant to stop on time. But you're getting the idea that you can look at each of these. We have to stop real soon. I'm really sorry. I just lost track. Anyway, so we should adjourn. Go ahead with your question.
Oh, okay. I'm just thinking about like all the unintentional consequences that come with like moving towards single payer. I guess we talk about administrative costs and like the software and things like that. But I'm just thinking about all the people, the middlemen, because we're talking about administrators, but these are, actual people that have jobs and livelihoods depend on these jobs. And also the software companies, like, I have friends that are software engineers and things like that. How would this deal with that? Like making sure that like if we cut out all those administration fees, then a lot of people won't get paid. A lot of people won't be able to live. So how do we reconcile that?
Before I start my answer, Dave Himmelstein, who will be here at 1, if you have time at the end, you could actually ask him that question because he kind of did a study on turbulence in the labor market. So, okay, there's 2 parts to the answer. One is what would actually happen, and the other is the political consequences, which are harmful. That you've got now approximately, I think, 500,000 unnecessary administrative employees in the U.S. It's a fair amount of people, fair number of people. So they may oppose the reform just because they would lose their job. So that's a potential political obstacle to single payer reform. On the policy side, there is a lot of churn in the economy. There's actually 500,000 is, I think, about the number of jobs we turn over every month. So a big country with a big economy like the United States can handle it. Gerald Friedman, who's going to speak to you 2 weeks from today, I think, is going to address the economic impacts of single payer reform. So I think your question should get 2 answers. One is the political side, which is largely harmful to any effort for reform. In the lives of these individuals who are losing their jobs, they may face meaningful turmoil. But when you hear Gerald Friedman talk about the ultimate economic effects, you may draw a different conclusion. So
There.
this is
Good.
a question going to be, we're going to return to several times in the internship, at least twice during the internship further. But you could ask Himmelstein if you have time at the end about what he found about this turnover, loss of administrative employment, because he did do a study on it.
Okay.
Anyway, I'm so sorry we went over it. I'm so sorry. And please go on time for Dr. Himmelstein because he's a real superstar, and I think you'll really like him. He's really lucky that we got him for a slot. And after Dr. Bernheim, what he says, I think you'll find really interesting too. Okay, so thank you very much. I'm so sorry I went over, and I'm going to text Nurali now, or Slack Nurali. Take care, everybody. I'll see you Tuesday, or Monday rather. Sorry.